I'm Melissa Arbuckle. I'm the Vice Chair for Education, and I'm pleased to share with you some announcements before introducing our speaker today. So Dr. Christina Hoven received a 3-year, $3.2 million R01 from the National Heart and Lung and Blood Institute for a project titled Sleep and Wellbeing in High-Risk Youth. Congratulations to her. There are 2 members of the Columbia Psychiatry faculty who will be receiving awards at the annual meeting of the American College of Psychiatrists in February. Dev Devanand will receive the award for research in geriatric psychiatry, and I'm very pleased to also be receiving an award for my work co-chairing the National Neuroscience Curriculum Initiative with the award for creativity in psychiatric education. Thank you. Next week's Grand Rounds will be Howard Levin. Dr. Levin is an adjunct associate professor of biomedical engineering here at Columbia, and the title of his talk will be Finding the Interface Between Mental Health and Engineering, a New and Very Large Frontier. I'm sure it's going to be a very exciting talk. It is my pleasure to introduce Dr. Sidney Hankerson for today's Grand Rounds. Dr. Hankerson is an assistant professor of clinical psychiatry at Columbia University Medical Center here. He's a primary investigator of an NIMH-funded study to train African American clergy how to identify, support, and refer depressed community members to mental health care. The overall goal of his research is to increase access to quality mental health care in under-resourced communities. Dr. Hankerson completed his undergraduate studies at the University of Virginia. He then completed a dual MD-MBA program at Emory University School of Medicine, where he also did his residency training in psychiatry. While at Emory, he was also a chief resident. He then came to Columbia in 2009 as a mood and anxiety disorders research fellow in our NIMH-funded T32 program. He's had really an incredibly successful career. He was an invited participant to President Obama's White House Dialogue on Men's Health in January of last year. He was also recently appointed to the American Psychiatric Association's Council of Minority Mental Health and Health Disparities and the Council of Faith and Community Partnerships. Today, he's going to speak with us on partnering with churches to promote mental health. Please join me in welcoming Sidney Hankerson.
Good morning, everyone. I said, good morning, everyone. Good morning. I know it's Wednesday morning, but in the spirit and tradition of the Black church, I thought we'd start with a little call and response. So I wanted to make sure you all are with me this morning. First, I'd like to thank you, Melissa, for that very warm introduction. And during our time together, I'm going to talk about our work with partnering with African American churches to promote mental health. I'd like to thank my primary mentor, Dr. Myrna Wiseman, and I'd also like to thank my research mentor, Dr. Lisa Dixon, who have been invaluable in mentoring me and guiding me throughout this process. Ken Wells and Loretta Jones at UCLA are my other mentors. I'd also like to honor the legacy of Dr. Phyllis Harrison Ross, who died on this past Monday from lung cancer. Ms. Lachey Morris is was project coordinator on the study. And 1 Corinthians Baptist Church and St. Charles Borromeo Church are the 2 church study sites for our work. And the Community Coalition for Mental Health, I could not do this work without them. They serve as the leadership study structure for our studies. I'd like to first begin with an exercise. At all of our community advisory board meetings, we first begin with an icebreaker, and I'd like to do that now. So if each of you could please turn to your neighbor and share with them the story of your name. So who named you? What's the meaning of your name? And how has your culture, if at all, shaped your name? And anything else significant about your name that you would like to share. So please turn to your neighbor and share the story of your name now. So about 30 more seconds. All right, if we could wrap it up. I hear a lot of laughter, but we need to wrap it up. Well, I hope you enjoyed that exercise and learned a little bit something about your neighbor that perhaps you hadn't before. And one of the purposes of that exercise, in addition to trying to build community and learn a little bit more about your neighbor, is to teach us that, sometimes things that we don't think about our name follow us. And that could be positive and negative. And in the Black community right now, unfortunately, there's a negative story as it relates to mental health treatment. And in our country, on the last year, we've been confronted publicly and repeatedly, unfortunately, with the murders of Black men. And despite this ongoing trauma in communities of color, there are low rates of mental health treatment for groups that sorely need them. So the overall aim of all of my research activities are to reduce mental health treatment disparities among African Americans by partnering with churches. And my goal is to hopefully change the story that communities of color talk about and relate as it comes to mental health. And we all have a huge role to play in changing that story and changing that narrative. So during our time together, I'm gonna walk you through the process that led to my current K Award. We'll go through depression epidemiology and disparities in care, the invaluable role that faith-based settings in the Black church have played as de facto mental health counselors, and then the NARSAD study that I got to study and test the feasibility of implementing group IPT, and then my current K Award, which is to implement mental health first aid. So we all know that major depression is a debilitating illness. It is now actually the #1 cause of disability in the world. And the association between depression and race is a complex one. This is a very large, nationally representative, community-based survey, the National Epidemiological Survey on Alcohol and Related Conditions. And Dr. Deborah Hassan from the School of Public Health showed the prevalence of depression by race between African Americans and non-Hispanic whites. And you will see that African Americans have lower rates of lifetime depression as well as 12-month or current depression compared to non-Hispanic white adults. And then in another survey, the National Survey of American Life, which was conducted between 2003 and 2004, we see a similar pattern. African Americans have lower rates of lifetime depression and lower or similar rates of 12-month or current depression, even though African Americans are disproportionately exposed to risk factors that would increase their risk for depression. However, African Americans who are clinically depressed suffer a great deal. The National Survey from American Life looked at the disability among those adults who were clinically depressed to see who was more impaired. And although African Americans with depression have lower prevalence rates of depression, they are indeed more impaired in the work elements of the Sheehan, the relationship and social functioning, and overall disability. African Americans with depression were more significantly disabled. So you would think that given how impairing depression is among African Americans, we would be running to everyone here at PI to get treatment. Unfortunately, we know that's not the case. African Americans and Mexican Americans have the lowest rates of depression treatment in the United States. And despite several initiatives, federal, local, and state initiatives to try to reduce these disparities in care, these disparities persist. So as a young T32 fellow at Columbia, I began my exploration of disparities by looking at treatment rates of depression and what types of treatment was received. And so looking at data from the National Epidemiologic Survey on Alcohol and Related Conditions, we found significant and persistent patterns of underutilization for depression. Black adults who were depressed were nearly half as likely to receive any treatment compared to white adults who were depressed. However, Black adults were nearly 2 times as likely to be hospitalized when presenting with a major depressive episode, indicating that Black adults may be more likely to present at a later time of disease or may be more severely impaired, as the previous data showed. So as we talk about health disparities, we know that socioeconomic factors, health insurance, education, and environment plays a big part. Fear also plays a big part. And as mental health professionals, we have contributed to some of the fear that is contributing to the underutilization of treatment in the Black community. This is actually a picture from a medical journal in 1972. Assaultive and belligerent. Now you can't tell me this doesn't look like James Brown. So you have in a medical journal, assaultive and belligerent, and cooperation with Haldol. And so this is, contributes to some of the implicit bias that we as clinicians may have when we see Black and Latino men. Because we know that Black and Latino men are more likely misdiagnosed when they present with psychotic symptoms as having schizophrenia, when in fact they should be diagnosed with bipolar disorder or major depression with psychotic features. So our own clinical bias may contribute to some of this fear and distrust. Well, how do we study depression in the Black community if there is this fear and distrust? I'm so glad you asked. It can be hard. It's challenging. We all know about the infamous Tuskegee study, in which Black men were lied about the treatment that they were actually not receiving. And this study still permeates through homes and communities today. So there's great distrust with researchers coming into communities and wanting to conduct research, particularly in the African American community. So given that, given the disparities in care, given the socioeconomic factors, given the fear, how do we address this on an individual and community level? Well, the good news is that African Americans are actually the most religious group in the United States. And churches throughout this nation's history, Black churches throughout this nation's history have had a prominent role in promoting social justice and delivering health programs and providing social services to their community members and their congregants. 87% of African Americans belong to a religious group. 79% of African Americans say that religion is important. And 53% of African Americans attend church at least once per week. And this is research from the Pew Foundation. So churches indeed have been a huge part of the cultural fabric of African Americans, and also on a public health perspective, have the opportunity to reach broad numbers of people. In addition to the invaluable role that churches play socially and culturally for African Americans, clergy throughout the United States play an invaluable role as mental health practitioners. This is data from the National Comorbidity Survey replication. And among those people who had a diagnosable mental disorder, clergy were second behind non-psychiatrist mental health professionals as being the people first contacted by those who have a mental health problem. So clergy are truly frontline mental health practitioners. However, study after study showed that clergy lack the training and don't feel as comfortable providing the services to folks who see them when they present with a mental health problem. So given this knowledge of the disparities and the important role of the church in the Black community, Dr. Wiseman and I set out to explore what had already been done in the role of churches as it relates to mental health. So I did a lit review, and we found over 1,400 studies that had been potentially eligible for people that had conducted church-based studies in which DSM-4 disorders were the primary outcome, in which 50% of the target population were African American, and in which there was at least quantitative or qualitative data reported. Of those 1,400 potential studies that initially were identified, only 8 studies met that inclusion criteria. So scant research has been conducted on this area. And there was only one study on depression. The one study that was conducted in a church that focused on depression involved 7 women who were conducting group CBT at a small church in Tennessee. And at pre-intervention and post-intervention, their depressive symptoms reduced in severity. Still, that signaled to us that there was a good opportunity to explore the role of churches in promoting mental health. So we explored and we saw that based on what New York City clergy had faced, the most pressing issues that clergy face in New York City are grief, marital problems, and depression, based on a survey that was conducted in 2005. And so I happen to have a mentor who knows a thing or two about grief and marital problems. So we investigated what had been done in terms of what could be potentially transferred into churches. And so we patterned our study on a trial that had been conducted in Uganda, in which group IPT was implemented and was amazingly successful in reducing depressive symptoms in a very traumatized community in Uganda. So that served as the template for my NARSAD study. So the aims of the NARSAD study was first to explore perspectives among clergy through conducting focus groups. This was the first time that we would be embarking upon delivering services in faith-based settings. So we wanted to see what the pastors had to say. We also wanted to assess the depression needs with screening through the Patient Health Questionnaire 9. And lastly, we wanted to test the feasibility of delivering group IPT in a large church setting in Queens. And so I'd like to tell you a little bit about the church in which this study was set. This church is set in Jamaica, Queens, and it has a congregation of over 20,000 people. So many people would say it's not a church, but it's a small town. But it's obviously a very large church. It has a lot of resources. It has over 100 ministries or volunteer programs that serve the greater community of Jamaica, Queens, as well as its congregants. So it's a very established church. And we conducted focus groups with 23 of the pastors on staff. The overwhelming majority of the pastors with whom we conducted the focus groups had a master's degree or higher. 87% were women, and their average age was 54. So I'd like to share some of the themes of the focus groups that led to our next step of the research. The pastors from a very, again, educated cohort said that racism, in their views, was a cause of depression in the Black community. One of the ministers said, the effects of slavery and white supremacy and institutionalized racism, all the things that we talk about in the Black community, can cause depression. So that was a key theme. The pastors also identified stigma as a key theme. This pastor said, as African Americans, we just never get help, and we think that counseling is not for us. We think it's for that other culture. And the pastors were very clear that they didn't want us coming to do group IPT. They said it wouldn't be feasible. And their main concern was that someone within the groups would break the confidentiality of the group and share information that had been disclosed with the greater congregation, or with the greater community, and that would leave the church open to be sued or some type of legal action. So they said that group IPT would not be feasible. And they also said that we had to partner with them. They mandated that a partner approach was required for this work to take effect. They said, you know, we like you, Dr. Hankerson, but you're not going to just drop in here with your little degrees from Columbia and think you're going to swoop in and do some treatment. But you have to partner with us through every step of this research process for there to be any way of it working. So with that information in line, we partnered with that church, and we're fortunate to partner with 2 other churches to identify the needs and the depression needs in the community. We distributed the Patient Health Questionnaire 9 at health-focused programs at 3 different churches, 1 in Harlem, 1 in Brooklyn, and 1 in Queens. And we were able to screen 122 people with the PHQ-9 at these 3 different churches. We found a significant percentage of men, 44% of our sample were male. The average age was 54, and the overwhelming majority were Black. I show you the total household income to show that churches truly are a hub for everyone within the community. We had a range of incomes, the most common being $35,000 to $69,000. So very diverse in terms of household income. Also very diverse in terms of education level. And 88% of the sample had some form of health insurance. We found that there were very high rates of depression at these 3 churches. Importantly, we found that although this was a convenient sample, we recruited at the church, and this wasn't a representative survey. They were convenient samples at health-focused programs at each three churches. But the overall rate of depression was 19.7% across all 3 churches. The other important fact that we found was that men had a higher rate of depression than women, which contradicts pretty much every epidemiologic survey that has been conducted to date. And we importantly found that through partnership, we were able to screen 122 people for depression. This led us to come up with a schematic that led to my K Award, which is titled Community Partnered Approach to Implement Evidence-Based Practices for Depression. Based on the results of the focus groups, Pastor said that, you know, in the Black community, we don't necessarily view depression as a biological illness, although we are aware of the neurotransmitters that are at play, but we see depression occurring within the context of chronic stress and the stressors that we face in our community. And if we can leverage the trusted position of the church to overcome some of the barriers that traditionally impede people from getting mental health care, by providing church-based mental health promotion, we can hope to make referrals to mental health specialists, to medical providers, to social service agencies, and hopefully culminate in community recovery. That led to the overall aims of my K Award, which is, again, to create a significant partnership, so to partner with key stakeholders, and we actually formed a community coalition. We want to train church leaders in an evidence-based intervention called mental health first aid. And we want to evaluate the impact of that mental health first aid training on knowledge, stigma, and referrals. So to begin with our work with the coalition and the actual partnership process, this is a busy slide. But this is the flyer that a group of key community stakeholders and myself, representatives from various schools at Columbia, from Teachers College, from the undergraduate university, from social service agencies, and key church leaders created to generate and inform the community about our study. And we decided to call the program Community Conversations on Overcoming Stress. We had over 300 people come out to St. Charles Borromeo Church in Harlem to hear the New York City First Lady, Charlene McCray, the Commissioner of Mental Health, Dr. Gary Belkin, and this is Father Greg Chisholm, who is the pastor of the church. So we had over 300 people to come and talk about how we can partner together and create a body that would serve as the leadership structure for this K Award study. And from that program, we solidified this partnership and created a website. And I'd like to show the website. This is our website, the Community Coalition for Mental Health, which is a 20-body group of just committed individuals, people who have, or family members who have, of those who have mental health problems, pastors, clergy, mental health professionals, who are focused on implementing the aims of this study and promoting mental health in Harlem. And we really focus on community academic partnerships. And this is the core members of our team. Dr. Martha Sullivan is CEO of Gouverneur Health, and she is one of our lead partners at St. Charles Borromeo Church. Erin Lee George is from the School of Social Work. Tina Brooks is at the Department of Health. Reverend Butler is from an organization called Harlem Congregations for Community Improvement. And this is Pastor Michael Walrun, who's pastor of our second church site. And Dr. Laura Smith is at Teachers College. And Sam Roberts is at the undergraduate university, head of the Institute for African American Studies at Columbia. Okay, so let's see if I can do this. Okay. So this is the body, this is the organization that serves as the leadership structure and body for our overall study. The second aim of our K Award is actually to train church leaders, to train pastors, choir leaders, deacons, deaconesses, people who will see people in the congregation repeatedly over time so that they can encourage them to get help. And we're going to be training them in what's called mental health first aid. Mental health first aid is an evidence-based intervention that was originally developed in Australia in 2001. And then it was adapted for the United States in the mid-2000s. It employs a 5-step action plan similar to CPR. Mental health first aid equips people with a 5-step action plan to help those who are experiencing an emotional crisis. And to date, over 740,000 people have been trained in mental health first aid in the United States. So mental health first aid is really like a toolbox. It equips people with the tools, lay people with the tools to identify the signs and symptoms of depression, of suicide, of psychosis, and other common anxiety disorders, how to listen to them in the moment, and importantly, how to encourage people to seek professional help or other support strategies. So these are the topics that are covered in mental health first aid trainings. So how are we in the process of getting participants for this study? I think the big thing to know about participant recruitment with community research is it takes a lot of time. We've conducted mental health workshops at churches during the week and on weekend. We have print ads, emails ads. I've been to dinners, although that was good. We've attended church services with our partner services. And as we've become more comfortable and the community has become more comfortable with us, we have certainly made referrals for mental health services. But it does take a lot of time. So we're currently in the process of evaluating the impact of our mental health first aid training. We're evaluating knowledge via depression and schizophrenia vignettes. We're assessing the trainees' confidence in being able to provide help to someone who's experiencing an emotional crisis. We're assessing their perspectives on stigma that they perceive, and as well as their perceptions on community stigma. And we're also assessing the participants' functioning with the short form Health Survey 12. And we're also going to be able to track referrals that people make to mental health specialists. And our assessments are given at 3 time points. We evaluate people before they take the training, and then immediately after completing the training, and then 3 months after taking the training. Thus far, we've trained 25 people at our 2 church sites, 1 Corinthians and St. Charles. So I'd like to share some success of our partnerships that we've had thus far. Last month, 1 Corinthians Baptist Church, which is the partner church for our K Award, recently opened a mental health clinic, and we've been working with them for the past 3 years. We've done focus groups with them, and we're going to be training mental health first aid to their church leaders. And actually, our project coordinator from the K Award is now a Columbia University School of Social Work student, and she's going to be doing her clinical internship at the church. So this is a way that our partnership has led to a success of implementation by increasing access to services for this community. And this was at the ribbon cutting ceremony last month. Another success of this partnership was I was fortunate to get funding to conduct mental health first aid trainings at the Manhattanville campus. And I want to publicly thank Dr. David Strauss and Dr. Scott Stroop for their help and guidance through this process. So along with Dr. G.D. Williams in the Department of Neurology, we are going to really be focusing on making this center a hub for wellness in West Harlem. I will be conducting mental health first aid trainings and workshops on signs and symptoms of depression and how to make a referral to mental health clinics. And Dr. Williams will be conducting his stroke awareness trainings, in which he uses rap music to teach kids the signs and symptoms of a stroke. So our next steps is that we want to be able to identify and map out those churches that are in Central and West Harlem who would be interested in receiving mental health first aid training. We really want to try to use Gary Belkin's word. We want to viralize mental health throughout New York City. And we feel that mental health first aid can be one part of the puzzle of changing the culture, helping people to identify the signs and symptoms of mental health problems, and being able to make referrals. And I'm very honored to have had this work and our partnerships to be able to translate into advocacy. Last January, I was fortunate to partner in President Obama's White House dialogue on men's health. And the reason I was invited to that was because of our depression screening study that we conducted that showed higher rates of depression among men. And so we're trying to develop ways, to engage men in mental health treatment. Long road of starting with disparities, going to focus groups, and now to implementation. Again, this process is time-consuming and labor-intensive. My mind and my head sometimes can be bouncing back and forth because I have to answer to a lot of different bosses. I have research mentors here, I have the NIMH, and I have the community members. And so it can be difficult at times to try to respond to all of those different voices. Thus far, we've had low completion rates with our 3-month follow-up surveys. We initially, in line with all of the other studies that have utilized mental health first aid, sent these follow-up surveys via Qualtrics through an online survey system, but it has not yielded a very good completion rate. So we've had to revise the IRB protocol so that we can actually go on site at the church and try to call people, and so that's been a long process in terms of getting the 3-month follow-up data. We also have to think about ways to recruit youth. Right now, we're just working with adults, but we definitely want to think about ways to recruit youth. And there is a youth mental health first aid that is being implemented in schools. And we have to figure out how to conduct research in smaller or under-researched churches. Our churches thus far have been very well resourced, so thinking about smaller churches will be important. And how to leverage. Most of our participants in our mental health first aid training have been older women, very highly educated. So how do we leverage, and they're retired and want to do something, so how do we leverage their enthusiasm and their passion to promote this work going forward? So in conclusion, reducing racial disparities is a very complex issue. and there's no single solution. However, I believe that church-based interventions may build trust and help to reduce some of the fear that is pervasive in communities of color. And partnerships and long-term commitment are required for us to have any inroads into making changes in these communities. Thank you.
Yes, thank you for your presentation. Really, really interesting work. I wanted to open up, you had mentioned that eventually there's a plan to incorporate group IPT, I'm guessing in the churches, is that right? Or you were talking about the Uganda as a model.
Right, right.
What is your thought about how that applies to this population?
Well, ultimately group IPT was not feasible. Because of, and I can go back to the slide, because of the concerns about liability and confidentiality. So we have moved away from group IPT and moved into mental health first aid. Mm-hmm.
Thank you for a great talk. You were talking about church as a locus for delivering services. Does religion ever figure into it?
Does religion figure into?
Well, the delivery of services. Mm-hmm. I mean, there are Christian-based kinds of therapies. You haven't said anything at all about religion. You've talked about church as a location.
Correct.
I mean, it could be in a barbershop. It could be a place where people gather. Yeah. I understand that's important. Yeah. But does religion ever play a part in terms of the substance of the treatment?
That's a great question. So does religion play a part in the treatment? I think that religion can be a bridge and a barrier to mental health services. I think that, many folks, myself included, who grew up in church, have heard that instead of going to see a psychiatrist or a mental health professional, you just pray it away, or you just need to try harder and have more faith. And so I think part of what our work is trying to do is try to change some of the culture around that, some of that notion that all you need is prayer or all you need is faith. So that's on the one hand. I think in terms of actual service delivery, there certainly are models. I know that CBT and I know that Dr. Lisa Miller has incorporated spirituality into IPT. So there are certain faith-based models. We haven't explored that as much, and my focus really is more on making sure that people get services. And I think that would be a great opportunity for growth to see how religion and faith-based services could be incorporated into this.
Myrna?
Well, first of all, congratulations, Sidney. You made it seem so easy, and I know how hard it was and how much work you put into this. I think there's a lesson here about precision medicine or precision psychiatry. When we went to do this study in Uganda, we wanted to do individual. In Uganda, they would not consider individual IPT or individual anything because it would have built distrust, because people live in communities and they work in groups, and they would not want to be in a room by themselves with a therapist of any kind. So it had to be group. So we naively thought, Uganda works. They're doing it now in 20,000 people in an implementation study. In the churches, black churches, what a great idea. Well, it was a terrible idea because of the confidentiality issues, the fear of protective custody, and we had to abandon that idea. In fact, I think we scared them away and had to, as all the work that Sidney's done, work with a partnership. Now, what I personally would like to see is that eventually this work gets taken up and by the churches themselves and the clergy, and it infiltrates into chaplaincy training, and that the chaplains, with help from professionals who do evidence-based treatment begin to incorporate this in their training. And that's where it will really be less than a mom and pop shop, but a real part of the church. And in that sense, they will incorporate religious ideas or language. And in fact, there's some interest in that. I've been contacted by some of the white chaplains who want to learn more about psychotherapy. But again, I think it should be at the level of the training for chaplains.
Thank you. Could you say a little bit more about what the mental health for first aid, first aid for mental health is?
Sure, yeah. So mental health first aid is an 8-hour course. So it uses role playing. It's usually it's a large group, so we try to train between 20 to 30 people at a time. We use role playing and activities to train people in the signs and symptoms, risk factors for depression and suicide, anxiety disorders, psychosis, and substance use. So those are the big categories of disorders that are covered. We also go over pretty extensively the action plan that's kind of like the ABCs of CPR. So we teach people how to assess for the risk of suicide or harm, how to listen non-judgmentally, how to give reassurance in the moment and information, how to encourage professional help, and how to encourage other self-help and other support strategies. And so that is the course of the 8-hour day. It's a sort of certified course, and so just like CPR, your certification expires in 2 years, so folks have to get recertified. So that's what the day looks like.
Great, thank you. There was a question over here.
So the data that you've collected so far sounds like it's all about the uptake by people who would then become practitioners of mental health first aid. And can we understand that the 20-year research plan is to see how this has an effect on mental health of members of these church communities?
Yes. Yes. Yes, and yes. Yeah. Yeah, we definitely hope that because of the mental health first trainings that people will be more likely to seek services when they need it, and then their mental health will improve.
Great, yes, please.
Me?
Yes, yeah.
Hi, Sidney. That was a really elegant and wonderful presentation. Thank you. I'm wondering, with your church partners, are they interested or do they want some information from you about results prior to publishing or your analysis?
Yes. So whenever we complete any training, we go back through our Community Coalition for Mental Health and present the results at those meetings. And our community partners actually help with the manuscript writing process, which is part of why this process is very long. But they are involved through all aspects of the data collection, analysis, and then the reporting. Yes.
Bill Fisher.
Thank you very much. It's very illuminating, and it's a wonderful idea to work through the strong community organizations to try to overcome the stigma and the barriers to getting treatment. I was just curious, though. I understand the idea that people in the Black community, many people feel standard mental health treatment's not for us; it's for that other community, as you highlighted. But then, if the goal of the first aid program is to make referrals to established sources of treatment in the community, how do they present that treatment so as to overcome the stigma so that the referrals are likely to be followed through?
That's a good question. So how do we, if there's stigma about seeking mental health care, how do we overcome that stigma so that people will be more likely to seek it once they know that they may have a mental health problem? I think there are at least two strategies for that. One, I think, is we certainly, through our partner church, 1 Corinthians, want to try to expand that. So we really want to make that clinic as robust as possible, meaning that we want to be able to really treat as many people as possible through the church-based clinic. And I believe that that can be a model, quite honestly, for other churches that are large enough and to have the capacity to do that. So I think that's one way. I think the other way is to develop a list of trusted community mental health professionals with whom people have had good experiences, so that we feel trustworthy with them in making those referrals, as well as making a list of services that are not as culturally informed or culturally sensitive. But I do think it's a challenging issue.
Claudine, did you have a question? Okay. No, go ahead.
Hey, Sidney, great talk. So you talked about the need to change the story. Mm-hmm. And it looks to me like there were at least 3 stories that you had to confront. The first is the story about mental health and mental health treatment. The second is about research, because fundamentally you were doing research and collecting data. Mm-hmm. And I guess the third was also about the community attitudes about Columbia University, mm-hmm. which, as you have encountered and as you know, aren't always positive ones. But I want to think about that middle story for a second and just wonder whether you have any thoughts or reflections on your own experience talking about research participation mm-hmm. with a group of folks who aren't necessarily eager participants, but also if you have any reflections about how we more broadly as an institution should be thinking about engaging the community so that traditionally underrepresented groups are better represented in research.
So the first question is, I guess, my reflection about engaging in research. I think a big part of how we have been accepted and how we have got buy-in through research is through the qualitative data that we've collected. By first conducting focus groups and interviews, that is a non-threatening way of conducting research, I think, for many people. And then through that partnership that we've established by being on site and explaining the benefits of research and empowering people to be a part of the research process, I think that research has become less threatening for the churches with whom we've worked. In terms of what we can do as an institution to engage communities, I think communities of color in particular, I think that we really have to look at this as a multi-year commitment. And I think that really just sitting down and talking to people and listening to their perspectives on their life experience will really shape how we approach this. Because in our focus groups, we thought we were going to do group IPT, but because of our focus groups, we completely changed the direction of our research trajectory. So I really think that, you know, there are opportunities for us to be seen in communities and for us to be present and for us to focus first and foremost on what's important to the people in the communities, and then letting that kind of be our guide.
Lisa Melman and then Ralph Wharton.
Thanks, Sidney. I'm thinking about the roles of 2 different groups. I was struck by the comment from the clergy about his own or her own personal experience with depression. Mm-hmm. And I wonder whether that kind of testimonial from church leaders is part of the plan at all in terms of breaking down stigma and providing role models. And then separately, in a totally different way, psychiatrists were very low down on the list mm-hmm. of people that are sought out. And I wonder if there's any particular role for psychiatrists.
Well, in terms of the first question, in terms of having people give testimonials, absolutely. So Dr. Dixon and I have actually had discussions about how we can video record folks sharing their story and posting it on our website. And I think that would be a huge, evidence shows that the best way to reduce stigma is through contact with someone who has a mental health problem. And so it would be amazingly powerful if a pastor or a church leader or community member got up and shared their story publicly. So we are looking for ways to do that. In terms of what's the psychiatrist's role, I think, in this is that, I think with changes in healthcare, I think as psychiatrists, it will be important for us to get outside of our 4 walls and to get out into the community. I think that, I am a very proudly trained psychodynamic psychiatrist. And I think that for us to really impact people who traditionally don't utilize mental health services, we're going to have to go outside of our kind of maybe traditional four walls.
Ralph.
Yes, I wanted to ask a more difficult question. I admire your courage in doing this, and I think it's a wonderful idea. But as an end result, I wonder if you have data on some important information like the actual suicide rate or the homicide rate or the marital discord rates. And then I have to say, in my own experience, I taught early on at Hallam Hospital, briefly in Manhattan State. And I've got to say that psychiatrists can be a risky job as well when you're dealing with severely disturbed patients, or even sometimes if you 2PC somebody and they come out afterwards and want to get you, which has happened to some doctors as well. So I'm wondering if you have the statistical data, but also about the wisdom or necessity to have African American counselors rather than white doctors go into these communities. What's your thoughts or the parishioners' feelings about that?
Yeah. Well, in terms of the first question about the statistics on suicide rate and homicide rate and marital discord, I don't have that data on me now. What I can say is that based on our patient health questionnaire, PHQ-9 surveys that we conducted in the churches, what I recall was the percentage of people who checked question 9, which asks about suicide, I think for men was about 3%, and I think for women was about 8%. But I'll be happy to send you that paper. Regarding who can go out into these communities, I think all of us can go into these communities. I don't think race is the key factor. I do think that race is an important factor. Have I had perhaps at times easier access into these communities because I'm Black? Yes. But I've also had a difficult time because I'm a psychiatrist. So I think that it's a very complex issue. I think that what communities of color are most important or most interested in is a long-term commitment. So it doesn't matter if you're white or Black or green. What matters is to people is that you're interested in them as a person and in their community and not just in a publication.
Yes, Deborah.
Sidney, it's so great to hear your work. I've been sort of hearing it around the edges for such a long time, and it's just fantastic. And I'm just going to ask something that I'm sure that you and Myrna have talked about so much, so I'd just be interested in hearing about it. You've made a decision to focus on identification of mental health issues and treatment, for example, rather than wellness and prophylaxis, this kind of thing. So, we ran into difficulties with groups about IPT because of confidentiality, but it's absolutely brilliant that the first thing that you said was about stress rather than depression.
Right.
So now you have a wellness center. I wonder, what you're doing in the whole mental health first aid thing is fantastic, but I wonder about leveraging the partnership that you have to start talking about wellness, and thinking about, more adaptive strategies and mindfulness. Well, there was a child fellow here a couple of years ago named Byron who did mindfulness hip hop as well. That was kind of like what G-Day does for his stroke, which was, I just thought so genius. Anyway, I'd just be interested to hear what you've been thinking about this.
I think that's a great idea, and that's something that I've not focused a lot on, and so I would love those and other ideas, and that's why we have the coalition, so that together we can have more synergistic ideas than just mine apart. But I think that's a great idea, to look at things from a wellness perspective. Yeah.
Stephen Heiler.
Thank you. Sidney, I know you're focused on the role of the churches in mental health. I'm just wondering, has anything been done, a collaboration with the churches and the congregations in terms of physical health, including things like making sure people get to a primary care doctor to see whether they get appropriate treatment for hypertension or diabetes, and other things. So is there anything we could learn as mental health practitioners that's already been happening? And I guess my idea about this, if you could get somebody in to see their primary care practitioner to deal with their physical things as a tangent, you might then get them included for mental health issues.
Absolutely. The overwhelming majority of those studies in that review, the 1,400 studies that we identified, looked at general health problems. So, the churches have successfully been used to, in partnership with, with researchers, to reduce conditions ranging from hypertension, prostate cancer, breast cancer. So the list goes on and on, diabetes, obesity. But really, there was a lack of studies with mental health.
Yes, Fran.
It was great to hear some of the details of your work, Sidney. And I just want to make a comment and then ask a question. My comment is, in many ways, the work you're doing is better linked to the direction mental health care for common disorders is moving in anyway, which is to have collaborative care models, or in any case, models where we're going to be teaching people in primary care how to treat the common mental disorders and perhaps use psychiatrists more for complexity. So I think that fits well with, de-psychiatristing it, if that's a word, for better or worse. But my question is, given that there were generally low rates of depression among, African Americans in the surveys that you cite, what do you think accounts for such high rates in the particular places that you've worked?
Thank you, Francine. I think it's a couple things that contributed to the high rates of depression. So first, to be clear, our screening was not a representative survey. It was convenient samples that we recruited at health programs at the church. For example, one program was called Code Blue, a focus on mental health. So I think that people who may have been struggling with mental health problems were attracted to this program in hopes that they would get resources. I think that happened at the other churches as well, because they also focused on health issues. So I think that it illustrates, for me, the fact that the church can really be a place, a trusted place where people who are experiencing emotional problems will congregate, and if we as mental health professionals can try to engage them.
Wei-Li?
So you mentioned some of the barriers of people going to seek treatment, and then you also kind of mentioned the historical background of misdiagnosis. Have you seen, it might be too early on to have gotten a sense of this, but even anecdotally, what are the institutional and systematic barriers to the people who are seeking treatment for them to be able to get the care that they need once they get their foot in the door?
You mean individually with the people we've seen, or just kind of globally? Yeah,
just like once people have gotten the referrals or have been identified as being in need, has anything come to your attention as like an additional barrier coming from the outside, from the mental health profession?
That's a great question. We're in the process of collecting that data in terms of the referrals and what are the barriers to that. I think that the biggest barrier is probably just access. I mean, it takes months to get into a clinic. So I think the biggest barrier is access. I do think the gentleman's point about stigma and kind of distrust of providers, I think, is a big point. But I think access is probably the biggest barrier.
Oh, yes, Lisa.
Thanks, Sidney. It was also great for me to hear you put the story together. And I have a whole bunch of questions, but I'll just focus on one for now. So, when it became clear that IPT wasn't happening, right? And so you're like, oh my God, what we're going to do? I'm interested in the dialogue around the use of mental health first aid, and how that was received, how you raised that, and sort of what was different about the reception for mental health first aid. I mean, I think we can imagine it, but I'm curious what you heard. And it sort of leads to this, to sort of just a second, maybe it's not a question, but it's a point.
So hopefully you'll remember my question by the time I'm finished with my point, which is that, my mind is going to, okay, we've got to get these people to treatment, and how are they going to get treatment? And then is this really going to help people? And then I say to myself, well, remember, this is community-based participatory process, and that what we need, that what needs to happen is that question needs to be answered together with the community, and that we always jump to sort of our solutions, but in fact this has to be a collaborative solution. But I'm curious, going back to sort of what was your sense of why mental health first aid was attractive and something that they wanted to do?
So I think mental health first aid, the coalition and the pastors at the churches were pretty clear why they liked mental health first aid. One, they thought it would be able to reach more people. By us training, multiple leaders at the church, from the choir director to deacons to ushers, they thought that more people would be impacted than just the pastors delivering one-on-one therapy or doing groups. I think the second barrier was that the pastors are overwhelmed. So they did not want to have any additional cases added to their already busy kind of counseling load. So I think the ability to reach more people and not wanting to burden the pastors more was why mental health first aid was attractive. In addition, I think that because Shirlane McCrae with NYC Thrive has put so much focus on mental health first aid, they were attracted to that as well and wanted to be leaders in that.
Other questions? Fran has another question. Francine?
I was peripherally involved in an effort to help the Muslim community following 9/11 through reaching out to, their mosques. And of course, we know this is going to be a very high stress time for the Muslim population under the current administration. And even though you have plenty of work to do with the African American population, I'm just wondering if you think this could be a good model for those. There are people interested in reaching that community. If you think this could be a good model for doing that.
Absolutely. Actually, when I took the training to become a mental health first aid instructor, there was a Muslim woman from Brooklyn who was talking just about that issue and the stress of, she was from Somalia, and the stress of just the refugee process, the immigration process, excuse me. We have actually identified a mosque in Harlem who is very interested in implementing mental health first aid. The imam actually has the DSM in his office, so he totally gets it. So I look at this as a total faith-based initiative.
Funny you should mention this. As sort of an avocation, I'd been invited to develop IPC, which is the abbreviated form of IPT, for primary care in Muslim countries by someone in Egypt through the World Health Organization. And we're almost done with the manual, so if anyone's interested, I'd be glad to share it. But by the way, there isn't much difference in working with Muslims than working with non-Muslims. Yeah, it was quite easy to adapt the manual. We asked for cases because we needed to know what they were talking about. That part was very easy.
Thanks. I also have a comment. That was excellent job, Sidney. This is referencing, I think, Lisa's point about maybe why mental health for first aid worked here. And I'm wondering what you think about it. This is my thoughts, is that, and it's also maybe Dr. Heiler, I think, mentioned this as well, is that in a lot of the churches, there are kind of massive pushes for screenings of general health conditions, as you mentioned, prostate cancer, breast cancer, things like that. And this is more in line, and then education.
Right.
And so this is very much in line with that for us, for our population, for mental health, right? So this is like PHQ-9 screenings and mental health for first aid and referrals. It's very much the same process that is already going on in many of the churches. So they're very familiar with like pushes for cancer screenings and then referral to treatment. So I feel like this is very much, there's an additional stigma, to mental health, but this is the way in. I think it's brilliant.
Yeah, thank you, Jean Marie.
Great. Well, please join us for lunch and we'll continue the discussion there. Thank you, Sidney, for a wonderful talk.